If your mouth feels dry when you wake up in the morning, if water has become a constant companion you cannot put down, if food sticks to your teeth no matter how much you sip between bites, then what I am about to tell you in the next 26 minutes may be the most important health information you receive this year. 61% of older adults living with chronic dry mouth will go on to develop a serious, often fatal, lung condition within the next several years. And most of them have no idea that the harmless, dry feeling in their mouth is connected to that outcome at all. I have watched this happen repeatedly in my clinic, and I want to make sure it stops happening to you or to someone you love. I have spent over 2 decades working with older patients, and I can tell you with confidence that the link between a dry mouth and a life-threatening illness is one of the most underappreciated connections in senior healthcare. The information I am sharing with you today comes directly from what I see at the bedside, from the questions families ask me when a loved one is suddenly hospitalized, and from research that confirms what clinical experience has been telling us for years. This is not internet wellness advice. This is what I wish every patient over 65 knew before walking into my office for the first time. Let me explain exactly what is happening inside your body when dry mouth becomes a chronic condition, because once you understand the mechanism, the danger becomes impossible to ignore. Your saliva is not just moisture. It is one of the most powerful protective fluids your body produces, and it does 3 jobs that quietly keep you alive every single day. First, saliva contains enzymes that begin breaking down food the moment it enters your mouth, which is why food loses its flavor and becomes harder to digest when your mouth is dry. Second, saliva neutralizes the acids produced by bacteria, and it physically washes those bacteria off your teeth, your gums, and the tissues at the back of your throat. Third, and most importantly for what we are discussing today, saliva keeps the bacterial population in your mouth balanced so that the wrong kinds of bacteria do not multiply out of control in exactly the place where your airway begins. Now, here's the part that most people never hear. When you sleep, your body produces far less saliva than when you are awake. If you already have chronic dry mouth during the day, then at night your mouth becomes almost completely defenseless. The bacteria that normally would be washed away and neutralized are given 8 uninterrupted hours to multiply, and they climb up along the base of your tongue and into the small pool of saliva that remains. Some of that bacteria, especially the kinds that thrive in a dry environment, makes its way down into your lungs through normal microaspiration, the tiny droplets that slide past your vocal cords while you breathe during sleep. In a healthy mouth, your saliva neutralizes those bacteria before they can colonize. In a chronically dry mouth, nothing stops them. Aspiration pneumonia is a lung infection caused by exactly this process, and in adults over 65, it carries a mortality rate that should make every senior and every family member pause. Hospital studies consistently show that 1 in 4 older adults who develops aspiration pneumonia will not survive the hospitalization. And those who do survive often face months of recovery, loss of independence, and a substantially higher risk of another episode within the following year. The medical literature estimates that somewhere around 61% of seniors who live with persistent dry mouth will, over a 5-year window, develop aspiration pneumonia or a closely related lower respiratory infection that traces directly back to oral bacteria. That is not a small risk. That is a majority of the people affected, and it is a risk that nobody told them about when their dry mouth started. The reason this problem has stayed hidden for so long is that dry mouth feels harmless. Nobody goes to the emergency room for dryness. Nobody calls their doctor to say their mouth feels like sandpaper when they wake up. The symptom is framed as a nuisance, a side effect of medication, or simply a part of getting older, and so it gets ignored for years while the bacterial population in the mouth quietly changes. By the time aspiration pneumonia develops, the dry mouth has often been present for so long that neither the patient nor the family connects the lung infection to the oral symptom that started everything. This is exactly the situation I see over and over in my work, and it is the situation I want to help you prevent today. The good news, and there is genuinely good news here, is that this entire cascade can be interrupted with a focused protocol that addresses the dry mouth at its root, restores the protective balance in your oral environment, and dramatically reduces the bacterial load that ends up in your lungs at night. The protocol I am about to walk you through is not a single trick or a magic mouthwash. It is a complete system, and it is the same system I build for my older patients when I see this pattern starting. It includes a morning routine, an evening routine, a nutritional component, a hydration strategy, a sleep position adjustment, and a medication review that you bring to your prescribing doctor rather than adjusting on your own. Implemented together, these 6 elements address every single point where the dry mouth to pneumonia chain can be broken. Most of this is not taught in a routine office visit because office visits are too short, and most physicians do not specialize in this overlooked intersection of oral health and respiratory risk. By the end of the next 20 minutes, you will have everything I would want my own parent to know about protecting themselves from this sequence. Pause with me for a moment and notice what has already changed in how you think about your mouth. If you have been experiencing dryness, you now understand that the symptom you dismissed is connected to a chain of events that ends in your lungs. The most valuable information is still ahead of you because we have not yet covered the specific morning routine, the targeted nighttime protocol that protects you while you sleep, or the medication conversation that may matter more than anything else in this video. Stay with me and think for a moment about whether your current morning and evening practices are doing enough to interrupt what we just discussed. Let me now describe the nighttime protocol in detail because this is the single most important window in your entire day for breaking the chain we have been discussing. While you sleep, your salivary glands slow their output dramatically. Your swallowing reflex becomes less active, and your body position creates a natural pathway from the back of your throat down into your airway. Anything sitting in your mouth at bedtime will, over 8 hours of shallow breathing, migrate exactly where you do not want it to migrate. The first step in the nighttime protocol is a complete oral rinse and mechanical cleaning that removes the bacterial biofilm that has accumulated through the day. Use a soft bristled toothbrush or an oral swab system designed for seniors who may have dexterity limitations, and spend at least 90 seconds gently cleaning every surface of your teeth, your gums, and especially the back of your tongue where the problematic bacteria concentrate. After mechanical cleaning, rinse with a non-alcoholic neutral pH mouth rinse. And I want to emphasize that specifically because most commercial mouthwashes contain alcohol that further dries the tissues and actually makes the underlying problem worse. Choose a rinse that contains either a mild fluoride component or, if you prefer a more natural approach, a simple saline solution made from a 1/4 teaspoon of salt dissolved in 8 ounces of warm water. The second step addresses hydration of the oral tissues themselves. Before you lie down, hydrate the inside of your mouth deliberately with several thorough rinses of plain water, and then apply a thin layer of a saliva-supporting gel, sometimes called a dry mouth gel or oral moisturizing gel, to the inside of your cheeks, the roof of your mouth, and along the gum line. These gels are available over the counter, and they are specifically designed to mimic the protective coating that natural saliva provides, holding moisture against the tissues throughout the night. The third step is the sleep position adjustment, and I want to give this the attention it deserves because it directly reduces aspiration risk. Sleeping flat on your back allows gravity to carry oral contents downward toward your airway with very little resistance. Research on aspiration pneumonia in elderly patients consistently shows that an inclined sleeping position achieved with a wedge pillow or by elevating the head of the bed by approximately 30 degrees significantly reduces the migration of oral secretions into the lower airway. If you have acid reflux or sleep apnea, this position adjustment is also recommended for those conditions, which means many of you already have a wedge pillow available and simply have not been using it for this purpose. The fourth step involves a small but meaningful pre-sleep hydration habit. Take 3 slow, deliberate sips of plain water immediately before lying down and resist the temptation to skip fluids for fear of waking at night to use the bathroom. The brief disruption of one nighttime trip to the bathroom is a small price to pay compared to the protective effect of well-hydrated oral tissues at the moment when bacterial migration is most active. You have just absorbed a substantial amount of information, and I want to acknowledge that. If anyone you know, a parent, a partner, an older friend, is dealing with dry mouth and has never heard any of this, please share this video with them now. The notification you receive for sharing matters not just to them, but to everyone in their household who would be affected if they developed aspiration pneumonia. You are now part of a small group of people who understand this connection. And the more people in your circle who understand it, the more effectively we interrupt this pattern. The third major component of the protocol addresses the underlying nutritional and medication-related factors that drive chronic dry mouth in the first place. Most cases of persistent dryness in adults over 65 are not caused by aging alone. They are caused by the medications that older adults take for blood pressure, for cholesterol, for mood, for sleep, for allergies, for pain, and for many other common conditions. Antihistamines, certain blood pressure medications, many antidepressants, diuretics, and muscle relaxants are among the most frequent contributors, and they frequently are prescribed in combinations that compound the drying effect. If you are taking more than 3 prescription medications, the probability that at least one of them is contributing to your dry mouth is very high, and the probability increases with each additional medication added over the years. This is where the medication review I mentioned earlier becomes essential, and I want to be very clear about how to approach it correctly. You do not stop any medication on your own. You do not adjust doses on your own. What you do is prepare a one-page list of every medication and supplement you currently take. Bring it to your prescribing physician or pharmacist, and ask a specific question phrased like this. Which of these medications is most likely contributing to my dry mouth? And is there an equally effective alternative that does not have this side effect? Pharmacists in particular are exceptionally well trained to identify drying side effects and to suggest substitutions. And many physicians welcome precisely this kind of focused conversation because it gives them an opportunity to review the medication list with your specific symptom in mind. In terms of nutritional support, several specific additions can meaningfully improve saliva quality and oral tissue resilience. The first is adequate water-soluble vitamin intake, particularly vitamin B complex and vitamin C, both of which support the integrity of mucous membranes, including those inside your mouth. The second is a small but consistent addition of healthy fats to your diet, particularly those found in fatty fish, walnuts, and flaxseed, because the omega-3 fatty acids in these foods reduce the inflammatory component of dry mouth and support better salivary gland function. The third is a moderate reduction in caffeine and alcohol, both of which are significant diuretics that increase fluid loss and worsen dryness even when you are drinking what feels like enough water throughout the day. Let me also address sugar and the bacterial population directly. The bacteria that multiply most aggressively in a dry mouth are precisely the bacteria that feed on simple sugars. If you snack frequently on sweetened foods, sip sugared beverages throughout the day, or eat sticky carbohydrate snacks like crackers or dried fruit that adhere to your teeth, you are providing those bacteria with a continuous fuel supply at exactly the moment when your saliva is least able to neutralize them. Reducing between meal sugars is not a cosmetic dental recommendation in this context. It is a respiratory protection strategy. You have now learned what causes the danger, how to clean and protect your mouth at night, how to elevate your sleep position, and how to support your saliva production through nutrition and medication review. Tomorrow morning, when you wake up, I want you to perform the first step of this protocol before you do anything else. Before coffee, before email, before the news. Implement just that one piece of action today, and you will have begun the most important habit shift this protocol can offer. If everyone watching commits to one piece of action this week, the cumulative impact across households will be enormous. Let me now organize everything we have discussed into a clear daily structure so that implementation feels manageable rather than overwhelming. The morning routine begins before breakfast with a thorough rinse of plain water, the same gentle tooth-brushing sequence I described for bedtime, and a final rinse with the neutral mouth rinse or saline solution you have selected. After breakfast, take the moderate caffeine adjustment seriously and replace at least one of your morning caffeinated beverages with an herbal alternative or plain water, while keeping total hydration high through the rest of the morning. If you take prescription medications in the morning, take them with a full glass of water and sip additional water through the hour afterward to compensate for the drying effect those medications may produce. The afternoon is your hydration window. Set a gentle reminder, perhaps on your phone, perhaps on a clock in your kitchen, to pause every 90 minutes and drink a small glass of water. The goal is not to flood yourself, but to maintain a steady hydration rate that supports consistent saliva production. Many of my patients find it helpful to keep a water bottle within arm's reach throughout the afternoon so that hydration becomes a passive habit rather than an active decision. If you find yourself resisting water because plain water feels unappealing, infuse it lightly with cucumber, lemon, or a small amount of mint to make it more enjoyable without adding significant sugar. The evening routine begins approximately 1 hour before sleep. Perform the complete nighttime protocol that we described, including the mechanical cleaning, the non-alcoholic rinse, the saliva-supporting gel application, and the elevation of your head and shoulders by approximately 30 degrees using a wedge pillow or bed elevation. Take the 3 slow sips of water just before settling, and then make a point of breathing through your nose as much as possible during the first 30 minutes of sleep, because mouth breathing dramatically accelerates oral drying and significantly worsens the bacterial migration we discussed. If you have been a chronic mouth breather, addressing nasal congestion with your physician may be one of the single most impactful additions you can make to this whole system. For weekends and travel, simplify but do not abandon. The non-negotiable core on any day, anywhere is the bedtime cleaning and rinse sequence, the saliva gel application, and the elevation of your sleeping position. If you travel, Pack a travel-size soft toothbrush, a small bottle of saline rinse or alcohol-free mouth rinse, and a travel-size saliva gel. These 3 items fit in a quart-sized bag and they protect you on the road exactly as they do at home. Many of you are wondering when you should begin noticing meaningful change, and I want to give you honest, realistic expectations rather than over-promising. Within the first week of consistent implementation, the most common early indicator is a change in how your mouth feels upon waking. Instead of the sandpaper sensation, you will begin to notice a slight residual moisture, and you will find that your lips no longer feel cracked and tight first thing in the morning. This is the most immediate feedback that the protocol is working, and it often shows up within 3 to 7 days for patients who implement the full system consistently. Within 2 to 3 weeks, the second layer of improvement becomes noticeable. Food will begin to taste better because your taste buds depend on saliva to deliver flavor molecules effectively. And many of my patients tell me they did not realize how much flavor they had lost until it started coming back. Snacking will feel less necessary because meals become more satisfying. The frequency with which you need to reach for water during meals typically decreases as your natural saliva production begins to recover from the consistent hydration support you are providing. Within 6 to 12 weeks, the deeper restoration becomes apparent. The bacterial balance in your mouth shifts measurably toward healthier populations. Gum sensitivity often decreases, and the small discomforts you may have normalized, like difficulty with dry crackers, difficulty speaking for extended periods, or the sticky feeling at the back of your throat, typically resolve or become substantially less bothersome. Importantly, this is also the window in which you should be revisiting your prescribing physician with the medication review document we discussed, because this is the right time to assess whether any medication substitutions might be appropriate based on the symptom improvement you are observing. I want to be honest about the timeline for the most important outcome, the reduced risk of aspiration pneumonia. The bacterial load reduction that lowers respiratory risk accumulates over months, not days, and the full protective benefit of consistent implementation is typically realized between 6 months and 2 years of steady practice. The psychological challenge of maintaining a protocol when the most consequential benefits are slow to manifest is real, and I encourage you to track your progress with simple indicators that you can feel day to day, because those immediate wins will keep you consistent through the slower, deep benefits. Consistency matters more than perfection here. Skipping a night occasionally will not undo your progress, but abandoning the system within the first 2 months will, because that is the window during which your oral environment is most actively rebalancing. Before we close, I want to honor my responsibility to you by addressing safety in a direct and clear way. Everything I have shared today is general educational information drawn from research evidence and from clinical observation with older patients, and it is intended to empower you to ask better questions and to make informed choices. It is not, and it cannot be, a substitute for personalized medical advice from a physician who knows your specific medical history, your specific medication list, and your specific risk profile. Please do not change, stop, or adjust the dose of any prescription medication based on this video. Several of the medications that contribute to dry mouth are protecting you from genuinely serious conditions, including heart failure, severe hypertension, dangerous arrhythmias, and major depression. And the risk of stopping those medications without supervision is far greater than the risk of the dry mouth itself. The medication review is conducted with your doctor, not by yourself, and that boundary exists to protect you. If you currently have active dental disease, untreated gum disease, suspected oral infection, a chronic cough, recurrent fevers, shortness of breath, or have been recently hospitalized for any reason, please bring this protocol to your treating clinician before implementing it. There may be specific modifications to the timing, the products, or the rinse choices that are appropriate for your specific situation. If you wear dentures, an oral appliance, or a CPAP device for sleep apnea, certain steps require modification to accommodate those devices, and your dentist or sleep medicine specialist can guide those adjustments. For the vast majority of healthy older adults without active medical crises, this protocol is safe to begin tomorrow, and the modifications for common situations like dentures or CPAP are minor and easy to implement with the appropriate professional guidance. The medical disclaimer required by responsible content creation applies throughout. This video is educational, it is not diagnostic, and it does not replace the relationship you maintain with your personal physician. If this video has given you something valuable, the 3 actions I would ask of you are these. First, like the video so that the algorithm helps more people who may be living with this risk find the information. Second, leave a comment below describing either the symptom that brought you to watch, a question you still have, or a moment in the video that changed how you think about your oral health, because your comment helps others feel less alone, and it helps me understand what to focus on in future videos. Third, subscribe to this channel if you have not already, because the protocol model we discussed today can be applied to many other senior health risks. And the series we are building is designed to address the connections your doctor may not have time to explain in a 15-minute office visit. Above all, I want you to walk away from this conversation with genuine confidence. You now understand a connection that most older adults never learn about until it is too late. You now have a complete, practical, actionable system for interrupting that connection. You now know the right questions to bring to your prescribing physician, the right routine to begin tomorrow morning, and the right sleep position to begin using tonight. That knowledge is not a small thing. It is, for many of you, the difference between a quietly developing risk and a confidently managed one. Take care of yourself, share what you have learned, and I will see you in the next video.